this area type of tightness around this area already said C1, 2, C2, 3 needs to be screened for 4, 5, 5, 6. Right? So in this area already, it doesn't travel down. Don't care anything else. Just go here. Rotate. Chin, cranial, cervical top. Rotate. Chin, cervical top. Okay. Now you notice I never ask the patient anything because I don't rely on their feedback. If you rely on their feedback, they're pulling it on it. Most of the time, you are judging by their symptoms rather than judging by what is actually problematic. Right? Okay, so then I'll go down, okay, and then feel the feeling of this one. Rotate here, and then rotate here. I'm not even looking at her. Right? And then coming back. And then I already know there's a facet joint problem here. Because once she goes down, she rotate, gets a bit stuck here, okay, come back, and then in this position, if I do that, okay, she's a bit stiff, here, I can move, but if I go up higher, there's the SCM tightness from this morning that we talked about, from here, okay, then from there you go into the first rib, second rib, bouncing second rib very nice, first rib is not that nice, clavicle, pop it onto it, SC surface, SC is okay, it's a bit sunken here, which is nice. And then this one, slightly elevated on this side, nothing too much here. Okay, shrug shoulder to ear, yeah, good, and lower down, yep. So I did a little bit of quick strength test around that, should be quite clear around that. So at the end of it, if she's coming for a pinching here around this particular area, causing a cramping on this side, vector pull SCM here, so this one has to close down to just hold it counter. Potential. Number 2, neurally tight here, causing a neurally representation on the other side. Okay, so lie down, face up. Right, stop wasting time. Oh my goodness, we're gonna wait. So industry only have 20 minutes. You guys are already so freaking. So here, go, okay, positive there, and then 45 degree from here. This. Yeah, very quickly. Bam, bam, bam. Okay, there. Good. So, here. Go through. Pulling here just before I straighten out the other side. Move away. Yeah, good. Fully straighten. Good. Okay, let me go. It doesn't change. So the hypothesis of contralateral pull doesn't exist. Done. If it exists, it should make it
tighter. Contralateral, you tension up the other side.
No, because when you mobilize the other side, the pulling is down in the cord because it pulls like that, so the vector is this way. You are not thinking of pulling that way as such. So there's a classical increased neurotension on this side here, right? So we already said, how are we going to address the neurotension? Now onto your side. Neurotension is now going to be assessed on side line, especially with upper cervical component. We just drop her like that. She's okay, wouldn't die. Right, good. Here, in position, okay. Then we want to look at neurotension around this whole area here. Now we have 1 clavicle elevation, clavicle depression, posterior tilt scapula versus non-posterior tilt scapula. So what I'm feeling for is posterior scapula seems to improve it a little bit. Looks like she might have the thoracic component of it as well. So let's go here. Let's see how much her thoracic rotation is there. She can rotate it quite well. Usually I need to crack it, but it doesn't make that difference, right? So we have a pec minor component of the entrapment, and then we have a SC that is moving, but there's a bit of a front facial pulling around here. So we're gonna make the floss super fast. What does SCM do? SCM is the side bending towards, so we're gonna side bend it away, and then just in the way already. So what we're going to do, just in the position, we'll floss primary tension, tension. Okay, last one, tension, tension. Okay, she can maintain it there. Then I'm gonna floss SCM here. Turn neck towards ceiling. Turn, floss. Turn away, floss. So SCM is a superficial tissue. You don't chop into it. You make sure you pull. So turn towards. It allows me to pull on the SCM there. Okay, I floss, floss, floss. Turn away, floss like it, floss like it, floss like it, floss like it. Okay, I'm not even in hand of the elbow tension, but I just feel the rubber band, rubber band, rubber band, rubber band. Okay, good, done. Is associated with the opposite side CO1 that is not turning well. So why does the CO1 wants to do this? It's because CO1 here cannot cranial cervical flex, right? Because the tightness is being put in the front and she's rotated like that. So we need to get CO1 cranial cervical flex to the back. So I pin SCM, pull back this way, cranial cervical top, cranial cervical top, active, come on, active cranial cervical top, 1, cranial cervical top, 2, cranial cervical top, 3, cranial cervical top, 4, cranial cervical top, 5. This is proximal SCM facial mobilization. I'm not doing anything. Yeah, I'm just guiding the head how to cranial cervical top. And done. Okay, good. So then once you see stars ready, then I go, yeah, check, check, yeah, good. Full flexion here, cervical rotation this side, nice, good. Where pain? Here?
Insertion of
The SEM or?
no, behind. Occiput.
Occiput there, okay, never mind. Alright, so we check C1, 2, lateral flexion this way, lateral flexion this way. C1, 2 is flex, rotate onto it, extend, lateral flex, extend, lateral flex, extend. Oh yeah, there. 1, 2, 3, 4, 5, 6, 8, 9, 10. Okay, good. And relax back.